Welcome back to the second class of donovanosis. So in this class we are going to study about granuloma inguinale. It is the same as donovanosis, it is a synonym. This is the second part of the 3 series on this topic, and in this class we will study about the clinical features, the variants, the complications of the disease and the differentials. In the last class, we have already discussed the pathogenesis and the epidemiology. So, we'll start with the clinical features. If you have gone through the last topic I have taught, which was chancroid, you will be able to remember donovanosis more easily. So, first the site. The site in the genitalia for the ulcer of donovanosis is almost the same as on chancroid. In males, it is frenulum, glans, coronal sulcus, prepuce and penile shaft, while in females, fourchette, labia minora, vestibule and clitoris are the sites of predilection. Now coming to the sites of extragenital area, these are in donovanosis. The most common is the inguinal region. In about 10% of the cases, you will get an subcutaneous nodule or an ulcer over the inguinal region. Next, the perianal region. In about 5 to 10% it is affected. There can be affection of oral, mucosa, abdomen, chest. How do these sites get infected? It is most commonly due to autoinoculation or contiguity, that is the spread of infection along the dermis in nearby areas, or sometimes via blood and lymphatic drainage. Once the patient gets the infection of the bacteria, it takes about 3 days to 3 months, which is the incubation period, to develop the subcutaneous papules and nodules. And subsequently, these nodules enlarges and may ulcerate over the skin surface. Now, these subcutaneous nodules might be present in the inguinal region in about 10% of the cases, and it may mimic as if the inguinal lymph nodes are enlarged. So, they are also known as pseudobubo. True bubo is not present in donovanosis, that is, the lymph nodes are not affected per se in donovanosis. It might be affected with secondary bacterial infection or co-infection with other STI. How does an ulcer of donovanosis looks? We'll draw a diagram to understand. So this is how roughly an ulcer looks in donovanosis. This is the margin where the ulcer joins the surrounding skin surface. This is the edge of the ulcer, that is the wall of the ulcer. This is the floor of the ulcer, and on which the ulcer lies is the base of the ulcer. So the margin is sharp, that means the ulcer is very sharply defined. The edge is hypertrophic, you can call it elevated or overhanging, while in chancroid it was undermined. The base is indurated, it is hard, while in chancroid it was soft. The floor is covered with foul smelling serosanguinous exudate. It is beefy red in appearance, which is very characteristic of donovanosis, and it is highly vascular, so it bleeds easily. It is due to this beefy red fiery appearance of the ulcer, it was in history known as even flesh eating STI, which is not true, but the appearance was such that it seemed to be flesh eating. So we will write down the description of the ulcer. Since it is mildly contagious, the ulcer can be single or multiple. It is not as contagious as chancroid. It is painless, while chancroid was painful. It has sharp margins with the edge elevated or hypertrophic or overhanging, and it has a beefy red appearance which is very characteristic of Donovanosis, and it bleeds easily. Now we have seen kissing ulcers in chancroid. It can also be present in Donovanosis. Kissing ulcer, as already taught in chancroid, opposing skin surfaces might get infected to give a mirror-like ulcer on the other skin surface as well. Now we'll move on to the variants of this ulcer. There are 4 variants. The first one, which has already been taught, that was the first variant, and it is known as ulcerogranulomatous. The second one is hypertrophic or verrucous. The third one is sclerotic or fibrotic, and the last one is necrotic. The hypertrophic or verrucous, the edge is much more hypertrophic and the floor has warty granulation tissue. It is much more than in ulcerogranulomatous, and it is a bit pale looking. In sclerotic or fibrotic, there is a lot of fibrosis and sclerosis leading to scarring. The genitalia might get destructed. The last one, necrotic, it is due to superinfection by fusospirochetes. These are mixed colonies of Fusobacterium and spirochetes. Necrotic type is destructive and it is painful, while Donovanosis as such is painless. Now sclerotic and hypertrophic types are more common in females. The most common is ulcerogranulomatous. We'll move on to the complications. A very distinct complication in Donovanosis is pseudoelephantiasis. It is seen more in females and it is seen in about 15 to 20% of cases. Elephantiasis is caused by filaria. Here the cause is not filaria, so it is known as pseudoelephantiasis. Here what happens, there is persistent edema of the distant tissues. So there is enlargement of that area. So it is known as pseudoelephantiasis. The others are phimosis and paraphimosis seen in males. Then we can have, if there is a lot of destruction, there can be stenosis of the openings like the urethra, like the vagina, or even the anus. There can be a lot of tissue destruction, so the anatomy of the genitalia might get changed or disfigured. Lastly, there can be carcinomatous changes in prolonged cases of Donovanosis. There are very good photographs in Fitzpatrick, you can go through that. There has been even a report of amputation of penis due to the destruction. The infection can even extend to the internal organs like uterus and ovaries, epididymis and bladder, causing destruction of these organs. And if it is present in the oral mucosa, there might be adhesions between the cheeks and the gums, and there might be a lot of fibrosis leading to microstomia. So moving on to the systemic signs and symptoms. This infection can spread via the blood to other organs, distant organs like lung, liver, even bowel and spleen. Sometimes it may even affect the bones and joints. Among the bones, tibia is the most common. It might even spread to the ears, causing otitis media, mastoiditis, and cervical lymphadenitis. So this is how the beefy red ulcer of Donovanosis looks clinically. This is from the NACO website. and there is no lymphadenitis per se in duodenomanosis. So what are the differentials of this ulcer? The first category of differential is all the genital ulcer disease. In GUD, the first differential is syphilis, and all the three stages of syphilis like primary, secondary and tertiary comes under the differentials. In primary, the chancre is a solitary, non-bleeding, indurated ulcer, and it is associated with rubbery lymphadenopathy. In secondary, condyloma lata has a very characteristic moist, flat-topped appearance, and the treponemes can be seen under dark field when taken from it. The nodular ulcerative lesions of tertiary syphilis, especially if there is no lymphadenopathy, is confused with duodenomanosis, but the punched out appearance with a tendency of central healing and peripheral spread helps to differentiate clinically with the beefy red appearance of the duodenomanosis. Now second is chancroid. The chancroid is characteristically painful. There are multiple painful ulcers and with undermined edges, and there will be sooner or later some lymphadenopathy. So this helps in differentiation. The third GUD is herpes genitalis, especially in immunocompromised people like HIV positive patients. And in these patients, these ulcers are large and very the morphology change, so it may be confused with duodenomanosis. The response to acyclovir helps to differentiate, and they have given a special term pseudogranuloma herpeticum to these patients. The fourth one is the bubo of lymphogranuloma venereum. The close examination will help to differentiate that these are true bubo and not just subcutaneous nodules. The differentials other than genital ulcer disease are amoebiasis, especially in homosexuals. So this can be differentiated by microscopy or therapeutic trial. The second differential is carcinoma, and especially the epidermoid carcinoma in early stages. Now apart from this, cutaneous TB like lupus vulgaris may resemble this, and lastly the entity pyoderma gangrenosum also resembles duodenomanosis. So these can be differentiated by their respective diagnostic tests like serology and syphilis, and if not, then therapeutic trial will help us differentiate them. This brings us to the end of today's class. In the next class, we'll be learning the diagnosis and management of duodenomanosis. Thank you.